Welcome to Raaonline. Today's topic is recurrent implantation failure. Let us define recurrent implantation failure. So the definition states that the absence of implantation after 2 to 3 consecutive assisted reproductive technology cycles, both fresh and frozen embryo cycles, with a total transfer of more than or equal to 4 cleavage stage embryos or more than and equal to 2 blastocysts of optimum quality. The process of implantation and embryo-endometrial interaction can be explained as apposition, attachment, which is also called as adhesion, and penetration, which is also called as invasion. Now, recurrent implantation failure or implantation failure is not the same as IVF failure. This is a signaling between the embryo and the endometrium. So, here we see that there is a uterodomes and there are integrins on the surface of the receptive endometrium, and these are the trophoectoderm integrins, and there are also microvilli on the surface of the syncytial trophoblast. So between the embryo and the endometrium there is EGF signaling. There is also leukemia inhibiting factor signaling, and this leukemia inhibiting factor signaling is also there to the endometrial stroma, and there is an area where there is a localized depletion of the mucin 1. That is the place where adhesion and implantation takes place. Cytokine and growth factor regulation of changes in the surface epithelium is brought about by the substances secreted from the trophoectoderm. We discussed the recurrent implantation failure definition. So, the in vitro fertilization IVF failure could be the result of unexplained subfertility caused by oocyte-sperm interaction defects or implantation failures. The oocyte-sperm interaction defects are not intended to be considered in implantation failures in ART. As in the definition of implantation failure, we already mentioned that embryo is optimum quality. So, the definition of recurrent implantation failure in ART stands for 4+ weeks when the patient is beta HCG negative, that means there has been no implantation, or a 6+ weeks beta HCG positive when there has been no intrauterine gestational sac is seen. So, the phrase optimum quality is also debatable because the quality can be assessed by morphology or by pre-implantation genetic testing with next generation sequencing based tests. Implantation efficiency. It is the sum of embryo quality, endometrial receptivity and transfer efficiency. So, EQ, endometrial quality, plus endometrial receptivity plus transfer efficiency. So, the given constant in recurrent implantation failure are embryo quality and good embryo transfer techniques. So, the likely cause for improvement in one interventional arm of giving one treatment over the other is just the improvement in the endometrial receptivity. Endometrial receptivity can be influenced by anatomical factors, endocrine factors, vascular factors, thrombophilias, vaginal uterine microbiome derangements, and immunological factors. Now, the anatomical factors are the endometrial polyps, submucous myomas, uterine septum, synechia, thin endometrium, adenomyosis, endometriosis, chronic endometritis, and hydrosalpinges. So, other causes affecting implantation include the antithyroid antibodies, phospholipid-dependent coagulation defects, testing for anticardiolipin antibodies like IgG and IgM, and antibodies to beta-2 glycoprotein, the lupus coagulant testing for a recurrent implantation failure, seronegative antiphospholipid antibody or antiphosphatidylserine antibodies, prothrombin complex and anti-beta-2 glycoprotein antibodies. All these need to be tested when testing for the immunological cause for recurrent implantation failure. Coming to thrombophilias and infertility, women with infertility may represent a subpopulation of patients with undiagnosed systemic autoimmune syndromes in which the main clinical symptomatology is obstetrics. Therefore, it is recommended to evaluate antiphospholipid antibody syndrome in all patients undergoing IVF with the goal to recognize women at high risk for miscarriage. Furthermore, there are some causes of inherited thrombophilias like protein C and protein S deficiencies, and there could also be undiagnosed activated protein C resistance. Then other causes of recurrent implantation failure include factor V gene-laden mutations, factor 13 gene mutations, antithrombin 3 deficiencies, and prothrombin gene mutations. Now, uterine natural killer cells in endometrial tissue should also need to be tested using the immunohistochemistry or flow cytometry of the endometrial response needs to be assessed. Now this here blue is the baby and pink is the mother. So what we see here is the uterine natural killer cell, and this has been interacting with the trophoblast. So the trophoblast does not express HLA-A or B. So there is no interaction with this T cells. The trophoblast does express HLA-C and G, and the trophoblast HLA-C and G interaction with the uterine natural killer cells is there. Uterine natural killer cells tolerate trophoblastic invasion by binding of HLA-C, G and E to natural killer cell receptors, which are the KIR receptor and CD94 receptors. And after this interaction between HLA-C, G and E with the uterine natural killer cells, there is secretion of fibronectins and matrix metalloproteinases. Now these BF-beta upregulates the fibronectin expression and modulates the integrin expression, and this helps in the attachment of the embryo and the immunological acceptance of the embryo. Now progesterone in a pregnant woman, it inhibits the macrophage activation, so there is a immune suppression. Progesterone also stimulates the helper 2 cytokine expression, and helper 2 cytokines stimulate the uterine natural killer cell differentiation. PGE2 inhibits the lymphocyte proliferation. The B cells do not enter the implantation sites at the endometrium embryo interface, and there is no T cell activation against the trophoblast because of the absence of HLA-A and B on the trophoblast. And IDO activity inhibits the lymphocyte proliferation by tryptophan